welcome to BurnCast episode 11. And this BurnCast is going to be a little bit different than the ones we've done before. This BurnCast is going to focus on meeting our nurse practitioners so you can get to know them a little bit better. You guys have already met Liz, Weibel, and Ann on all of our other BurnCasts, but today we have Joe and Catherine, who are a big part of our trauma and burn team. So first, we're just going to go around and I'm going to have everybody introduce themselves and tell me how long you were a nurse before you became a nurse practitioner and how long have you been a nurse practitioner. And we'll start with Liz and then Ann and then Catherine and then Joe. Okay.
No specific order, right? Okay. So Liz Weibel, I've certainly had the pleasure of doing BurnCasts in the past. I've been an NP for 13 years with the Trauma and Burn Surgery Service, but more recently have served in the role as a PI coordinator for the last 4. Prior to that, I was a nurse for 9 years, and I'm going to move on to my next colleague before you can actually do the math.
Okay, I guess I'm next. My name's Ann. I have been a nurse practitioner for 8 years or so. Half of that has been with the trauma and burn team. And before that, I was a pediatric ICU nurse for 6 years.
I am Catherine. I have been with the trauma and burn team for almost 12 years as a nurse practitioner. And prior to that, I was also in pediatric intensive care as a nurse, not at Children's, for about 5 years.
And my name is Joe. I've been with the trauma burn team for almost 4 years now. Before this role, I was at Georgetown working in pediatric transplant for, I think, 6 years before I got my first job as an NP.
Wow. We have a super long-lasting educated group here. So going backwards, so Joe, what made you decide to become an NP?
So I really liked working at Georgetown. I think Anne has also worked there, maybe possibly you too, Catherine, a long time ago. And so for those of us that have worked there, it's kind of, you're kind of a little bit isolated, but that makes you learn really quickly. For example, for like lab draws and stuff, like there's no phlebotomy, there's like no resources really. So you're on your own. So it was great learning. But I just wanted to kind of like advance my education and be more helpful in like a provider focused role and just kind of keep growing. If you would have asked me back then, I would have said that I wanted to do emergency nurse practitioner, but doing rotations here, I really fell in love with the trauma burn role.
Have you always done peds?
Yes, always done peds. I feel like most peds people are like never adults. I only want to work with children. And then adult people, it's like the opposite. I almost like don't trust you if you do both. I feel like it's very, very different. So yes, always interested in peds.
Catherine, what about you? What made you go back to school? It's a big jump.
I had always planned on going back to school. I was fortunate and had some role models early on of nurse practitioners and had an understanding of the role, but thought it would be really important to have bedside experience prior. And that was solidified when I was in my PICU role. There were a few nurse practitioners that really stood out to me in the setting of in a hospital, but also nurse practitioners that were working with subspecialties that followed their patients while they were in the ICU, but also had a relationship with them outside of the hospital. There was continuity of care, and that just reinforced me a role that I would like to have. And I really enjoyed the acuity of an ICU setting and also the acuity that we get to see now, but also that there is continuity and that we see patients and families throughout their, for trauma and burn throughout the course of their illness or injury.
Did you all, was Children's your first NP job?
It was.
Wow. And would you ever work with adults?
No.
Me either.
I can't imagine. Cannot imagine taking care of adults.
Right.
But you know, like what we do get to see some adult patients, both as nurses and as nurse practitioners, in that it's very different caring for a newborn baby than it is caring for a 17, 18, 19-year-old
No
child
kidding.
/ adult. So I think that that's a unique perspective and experience for pediatric providers.
And what made you choose trauma and burn? Was it just something that just kind of happened, or were you like, this is the population I want to take
I
care
think
of?
both. Well, actually, maybe I shouldn't say this. I did a medical mission when I was in high school, and they were trying to figure out where I was going. And I remember saying, I don't want to do burns. And then when I was in college, I was a nurse extern summers, and again was getting placed at a hospital in New York, and they were talking about open units. And I said, I don't want to be on the burn unit. So I do find that that's interesting, and that's what I've done. And I just had no experience and no understanding. I definitely was drawn to the trauma part of it. And I think it wasn't my first job at Children's. I started in another role, and there was a lot of appeal to me for the trauma burn population, but also the role of the nurse practitioner in the team. And I've always seen and kind of identified nurse practitioners who have worked in like surgical services. Where I was as an ICU nurse, there was a few that were the hospital I came from, that wasn't Georgetown. I was there briefly as well, but they did transplant and neurosurgery, and their nurse practitioners were really strong and had a presence at the bedside, and also with having relationships with the patients and families.
And what drew you to trauma and burn? Because I know that we worked together when I was a bedside nurse, when you were an NP in the ICU. And I'm very glad that you moved to trauma, because I love having you on this team. But like, what made you go for the switch, and what drew you to this population?
Yeah, I mean, I really did love the ICU. I think I felt kind of like it has been a decade that I had been in the pediatric ICU between my bedside nurse and provider as a nurse practitioner roles. And it felt like it was time for me to do something that was, I mean, I guess maybe a little less intense in terms of the 24/7 shop of being kind of round the clock care. I also felt like the role in the ICU for me and for the role that I had was not as autonomous and robust as I enjoy on the trauma burn team. So what really appealed me to trauma and burn was that a little bit of what Catherine alluded to earlier, and that we cover patients in the ICU on the floor. We're outpatient as well, which I really enjoy burn clinic. I think that's like one of my favorites, although I have a lot of favorite aspects of the job, but I think that's one of my favorite aspects of the job. We're in the emergency department, in the trauma bay for consults and whatnot. So I really appreciate that we kind of see patients not just in their sickest time. And I think for a number of different reasons, that was kind of the right fit for me to switch, for the intensity in my life and my career, for the ability to see more in all of those different settings, and I think it is also more sustainable, and I have more of an impact in this role.
And Liz, so your background as a nurse, you were in the emergency department.
And actually, I started off in adults. I worked on an adult ortho trauma floor.
You did adults.
Yeah, I know. I'm the adult person here. And then worked in a combined ER, Mass General, that saw both adult and pediatric patients. But my motto was kind of always like taking the next step of what scared me, if you will. So I thought when I was working on an adult floor, emergencies scared me. So worked in the ER, and then decided that pediatric emergencies scared me, which is what drew me to the ED at Children's. And then finally, obviously, with that, the pediatric and burn population is just something that I, just fell in love with. So there we are.
So a free for all. Feel free, anybody can answer for like the rest of these, I guess. So our nurses, we're a teaching hospital, and our nurses interact with residents, with fellows, with attendings from multiple different disciplines, and they work with nurse practitioners. What should a bedside nurse know that's different about interacting with one of you guys versus like a resident or a fellow? I think everybody understands like interacting with attendings is always very different, but like, what's the difference?
I think that I nurse practitioners are on like team nurse. I think we're cheerleaders for nursing. I think because most nurse practitioners have some sort of clinical experience as a bedside nurse or as a nurse that we truly can relate to and understand. I think that there's also just some differences in the care, the kind of overall care of a patient that we have when we look at taking care of a patient. And I'm not dissing other providers or whatnot, but I think that nurse practitioners kind of take a bit more of a holistic approach.
Yeah, I would agree with that, Anne. And you know, all of our whole team, our background is bedside nursing. That's where we all like came from. So we truly understand when we place these orders, like what it takes to kind of execute them. And we will try to help in any way we can. Not that, you know, the residents and other staff members won't, but we really get it. Like we did it for years before being NPs. And I feel like it's important for everyone to know that we still truly feel like we are in nursing, like not that it's kind of separate. I feel like that's a misconception.
Yeah, I think that yeah, there's absolutely like no dissing for any other discipline, but I feel that like sometimes our bedside staff like doesn't, everybody kind of sees the blue and everybody wearing blue is like all together, but I feel like if I am working with one of you guys, I'm like, oh, thank God they get it. Like they know where I'm coming from because they did it. And sometimes I think that our bedside staff forget that of like, hey, like I look to you guys as our allies of like, hey, if I don't understand something, I know I can call Catherine and be like, dude, I don't understand this. And I'm not going to get somebody who looks at me like, why don't you know that? I'm going to get somebody who's like, hey, let me help you like understand that. And I appreciate that about our team.
I think that and also for our physician colleagues, I just think that our experience in that we kind of can speak both languages for nursing and more of the medical side, but also we factor that in for a lot of our decision making. It's really easy to say this is what needs to be done, but considering what that actually looks like for the nurses, for the patients, for the families,
the practicality of
that, yeah, how practical it is, what's really going to work, what is sustainable, and what is going to get us the best outcome. So I think that experience is unique.
And we know this population inside and out. That's all we do. All we do is trauma and burns. So if family members have questions, if, you know, even the patients have questions, again, I mean, I think we can all speak very, very much to, you know, procedures and outcomes and things like that. So please don't, if families have any questions, we are happy to address those.
So I think, is our model here at Children's different than other hospitals where the nurse practitioners see ICU patients and floor patients and clinic patients? Like, do all nurse practitioners, or are we special? I don't know.
It depends on
I think it depends on, yeah, I was going to say the same thing, the service and where the patients are located.
I mean, because generally you guys run the trauma and burn clinic. I mean, most of the time it's just you with the patient. So you do like all of that follow up and you see these kids like especially for our burn patients, like months down the line.
Yeah, I think that is also something that maybe sometimes people don't understand when it comes to doing the hands-on care in clinic. It is us. So the same things that nurses are doing or families are doing when it's patients in clinic, we're the ones doing it.
What would be like one thing that for any nurse that interacts with our team, and I'm going to ask each one of you this one, what is one thing that you would want the bedside nurse to know about, like when interacting with the burn and trauma team, and not just necessarily with like you guys as nurse practitioners, but like as with the team in general?
I feel like what I have to say is more specific to our team.
Okay.
As the nurse practitioners, kind of speaking to what Catherine just said, the fact that we kind of have to wear a lot of hats, right? So the inpatient provider has the patients on the floor that the 5 East nurses see, but then also we take the trauma burn kids that might be in the PICU, or we might be seeing burn consults in the ED. We might be helping the burn clinic provider because burn clinic is especially heavy that day. So we're kind of like doing more than one thing, multitasking. And I feel like a lot of the newer 5 East nurses come and they like shadow us in burn clinic and have a good sense of that role, but there's a lot of overlap. And so kind of to just understand our role a little bit more, and that it's a lot more than what they may see in any given day.
And we didn't even talk about you guys responding to traumas. Like that's another
Right.
thing.
Oh, yeah.
That can take a long time.
Mm-hmm.
I would say we're saying what you want nurses to know about the trauma and burn team, right?
Yeah, like what's
Just so that
one
I'm right?
thing,
Yeah.
like if you could have instill in every bedside nurse of like about interactions with the trauma burn team.
I would say that as much as I'd love to be there, I am not there 24/7 with the patients. So I am not the person who is seeing them. So I truly value a nurse's experience and the fact that they're in with the patient more often than I am, just because of the nature of the job of what Joe was speaking of. And that if you're concerned about something, I want to know about it, or if you want to talk, or you're worried about something, or you want to ask questions, like I think our team, especially when it comes to trauma and burn patients, if you have questions about the injuries or who's managing kind of the polytraumas or what to do with a burn dressing, or if you think something's sticking up and you want help with a bandage change, like there's so many things that I'm happy to discuss. And, the door in theory is always open unless we step out of the office and the door's not open, but like come reach out to us. And if you're having trouble with members of our team, reach out to other members of the team. But I want bedside nursing to feel like we're all working together, and that you can come to us if you're having questions about our patients, because really at the end of the day, we're all working together to get these kids better and out of the hospital.
And Anne, can you tell us where the nurse practitioner office is?
It is on
Because if you're not on 5 East, you don't know.
Mm-hmm. Yeah, it's on surgical care on 5 East, in the hallway in between basically like 503 and 513. And there's a sign on our door. And then you can search for us in the Zebra phone. We carry the trauma burn role, and you can always reach out to the surgical residents if you're having a hard time getting in contact with us, because they're also on our team. So does that answer your question?
Yeah, definitely. Because I was like,
Perfect.
I didn't know where your office was until I started working for trauma. I was like, there's an office? They're all together.
I was going to say that it may be a little bit more obvious for the nurses on 5 East, but just as for nurses everywhere to remember that one of the unique things about our team is that we have residents that are not children's residents. They are adult rotating residents from a number of hospitals, and that we collectively, our team, the hospital, the patients, we really depend on the nurses for being the nurses are the ones that have more experience institutionally as well as working with kids. And so I think it's really easy. And I think back to myself as a nurse, just to assume that, if you have MD next to your name, if you're a resident, you know all the things, and they know things that we don't know, but there's also so much knowledge that the nurses have, with understanding kids, understanding the system, understanding our patients, that the residents just cannot get by rotating through for a month. And so to continue to advocate for patients, and a lot of times if we're asking nurses to do things like, for example, like with some of the wound care, it may feel overwhelming, but they're the ones that have more experience often than some of the residents.
That's a huge point of something. And I remember when I was a new nurse in the PICU here, and I was terrified, as I should be, as a brand new nurse in a ICU taking care of like life and death situations. And I remember working with residents who were first year residents, thinking they would know all the answers, but they didn't even really know like developmental milestones the way that we were taught in our own orientation. So I think it's a good thing to remember, like, and I like the way you said, like, institutional knowledge of like how things work, and also just the pediatric patient in general. even for meds, and how quickly things can go awry if somebody who's ordering those meds doesn't know necessarily the pediatric dosing.
Mhm.
Liz?
Or thinking about like, liquid versus pills, or pre-medicating something that you might not pre-medicate an adult for. Maybe we should pre-medicate a child, how to talk to a child. Also some red flags that are unique to kids in terms of a child that may be decompensating that an adult provider may not recognize quite as quickly or easily.
Yeah, like a baby doc, not a doctor for babies, but a
Mhm.
baby doc might be extremely happy if there's a quiet child, while like that's a sign of like bad news bears if you have a quiet child. Yeah.
Interacting with parents, getting child life involved, like doing a bandage change, just the technique of putting a bandage on somebody is very different when they're a child and don't understand. There's so many expertise that are provided by our pediatric nurses, and it's very invaluable. So, good point.
And I'm just going to make a plug not only for our NP team, but our overall trauma nursing team, myself and Cindy and Jen Fritzine. There are patients that may no longer be on the trauma service. Maybe they once were, they've transferred to another service, but want to make that plug. If there are resources you need, if there are questions you have, please reach out. Cindy has done a tremendous job of compiling online resources and just has, so many rich references that we are happy to share with you. Again, even if it's not a trauma patient, or maybe it's a patient who's had a recent graft or something like that, we are happy to share some information with you.
Yeah. And while I have all of you here, I would love to talk a little bit about facial care for burns. I feel like that's one of the things that has continued to be like one of those like scary things that even like experienced nurses don't feel comfortable with. It is overwhelming, and it can be scary, but we can do this, and we can help you do it. It's just like how do we get there? And so Joe, why do you think that facial care can be so scary?
I think faces especially, that's kind of like the most traumatizing for not only patients, but also providers. That's not something you can just like, if it's on the arm, you just cover it up with a bandage. It's kind of always there. And all of us worry about kind of the long-term like cosmetic effects of having a burn to the face in terms of scarring and et cetera. And also the face is kind of the most dramatic. You have that great blood supply, but then when you're cleaning the face, it could be especially bloody. There's a lot of swelling. A lot of times their eyes can swell shut, and it's just kind of a lot going on. Some of these bigger burns have NG tubes, and it's hard to secure on the face, and it can get to be kind of a slippery mess with all the swelling and all of that like normal burn discharge. So that's kind of why I think faces are especially difficult in the burn population.
Anybody else have any other thoughts of like why it can be like it can seem like this insurmountable injury and like kind of scary for everyone involved?
Well, I think what you said was scary. It's scary for the patient as well to have anyone come at you, like at your face. And typically a lot of these patients are like a lot of our patients with facial burns are toddlers. They're scared anyway. Someone's coming at them. It doesn't feel good. Even after we have patients that are healed, like the idea of someone like rubbing stuff on your face and your neck, I feel like in a environment where you don't have any control, that's scary. That's overwhelming. So you also are dealing with the face. You're in the face of a very often screaming, overwhelmed, scared child that is moving and not staying still and trying to be as quick and efficient as possible. But it's incredibly overwhelming. And I will talk to parents about that in clinic and in the hospital. Asking a family to do that is a lot. And one of the things that we can do is help model for them how to do it. It does get better. It is, we have the, I don't want to say the luxury, we have the experience and we see the outcomes and see how well these heal. But in the beginning, for all the things Joe mentioned, it's incredibly overwhelming and looks horrible.
What happens if, so say So facial burns, they need to be cleaned a minimum of once or twice a day.
It depends on the location of the burn. If it's covered with a bandage, which some areas of the face and scalp you can cover with a bandage, we generally change it once a day. If it's open to air, we do cleaning and treatments at least twice a day. And so
Okay.
that can also be kind of challenging in that you can't have a long acting bandage on your nose. So there's a higher frequency of dressing change or burn care.
So let's say that we have a patient with just burns to like the front of their face that has no dressing, that it's, just Aquaphor. And say that doesn't get cleaned for 24 hours. What happens to the burn when it's not cleaned? And like the exudate isn't wiped off and you don't put fresh stuff on, like what happens?
I think that it's important, and this is a differentiation that's a little tricky. So we say we want it cleaned maybe twice a day, but we also want to make sure it's kept moist, because if it's moist, it's going to help it heal better. So what is going to happen if it's not being cleaned, if it's not being kept moisturized, is that there's more of a risk of infection. It can slow the healing down, and it can also make the subsequent care more difficult. And if you think about every time you're getting rid of that exudate that builds up the most, we often will say, the swelling and the drainage is the most in the first like 3-5 days. That is building up, that is creating like almost a scab or a pseudo eschar that the body's not going to recognize and doesn't think it should be there. So it is helping it heal faster. It's making it easier to clean each time versus having it build up. And often, and that's where I sometimes will say to parents who come in, for example, to burn clinic, like, let us really get a good clean, get to a fresh, like a clean start, fresh slate, and then try to stay ahead of it.
So the consequences of not doing this care twice a day they're bad. Like an infection, that's bad. Not healing, that's bad. The body not like scarring, that's bad. So this is like the facial cleaning and changing that dressing or wiping off the old goo and the old gross stuff that grew, and like not doing it. It's really important. So what could one of you briefly go through, like, what are the basic steps of cleaning a face? And we're going to say a face with just like Aquaphor on it, not like a not Xeroform or anything else, no bandages.
I think one of the biggest things that I like to highlight when it comes to facial care is, and one of the easier ways to do it is to use some sort of soak. So if you're trying to get what is ointment that was applied 8 to 12 hours earlier cleaned off instead of just scrubbing at it, or it's going to be a bit more abrasive, let it sit with either a warm soapy washcloth with soap and water, or sometimes we use Vash, and let it sit for 10 minutes if the patient will tolerate it. You can use screen time, you can let them sit with their parents holding them. I mean, I think there's a number of different ways to try and let something sit there, because that will do some of the work for you and some of the heavy lifting. And then from there, you do the best job you can to try and get it as clean, removing all of the old ointment and any drainage or debris that has come out of the burn itself. Old Aquaphor can kind of congeal a little bit or scab a little bit with the serous exudate that comes out of a burn. And so trying to get all of that off before applying more ointment.
Are they
as
using,
Joe spoke of earlier, you may have some bleeding. So just being mindful of that, it's normal.
Are they using saline with 4x4s or wound cleanser with, like, what are they supposed to be like wiping, like once they've soaked, what are they wiping with?
I think the most comfortable thing for patients is warm soap and water.
With what?
With like Johnson & Johnson or some other baby soap.
Okay.
Just like a very gentle, mild soap. Dove, Johnson & Johnson, and Vino, whatever it is. At the hospital, we have Johnson & Johnson. You can use Vash also, but I think they really seem to tolerate something warm better. I mean, if you can imagine coming at your face with a wound cleanser versus a warm soap and water. That's my personal kind of opinion. Not that I've ever had a facial burn before, but.
So so a lot of the time sinks aren't really near the beds. So is that when you would like get a tub of like warm soapy water
Oh,
and like
sinks.
yeah, sinks. So I'm just thinking like practicality for our bedside nurses that don't have sinks necessarily like right next to them. So should they like make a tub of like the warm soapy water? And can they dip more than once in the tub to clean the face?
Yeah.
Okay.
Yeah. I mean, you would at home, we offer and recommend getting patients in the bath or shower if
Right.
they will tolerate it. So you can act like you're giving them a bath.
Yeah. And would you suggest like washcloths or 4x4s for the cleaning? Does it, I mean, because sometimes it's nice to have like a prescriptive way of like saying like this is the best way that we found, like a washcloth with warm soapy water, and do like a nice like gentle like do you rub in a circle or do you just like wipe things away? Like which is the best?
That's a really good question. I think it depends on the burn. I mean, I think I sometimes use washcloths and sometimes use 4x4s and sometimes I go in circles and sometimes I give it a good, I hate to answer it that way. I don't know if Joe and Catherine have a different opinion, but I feel like it's a little bit of an art, not a science. And you kind of have to find what works best for the patient and for the provider.
Yeah, sometimes I'll even take baby soap directly, not even diluted, as like a gel, and putting it on and start rubbing to really soften things up. And then a clean, a warm washcloth or 4x4s to wipe off. For families, we do recommend that they just use clean washcloths at home. They don't need to clean with 4x4s. We recommend clean washcloths. But I think in the hospital, more often than not, we'll use 4x4s just to keep things clean and disposable. But for families, for at home care, warm soapy water, washcloths. If in terms of like little tricks, and I prefer a 4x4 over the cover sponges, because I think the 4x4s are rougher, and which sounds cruel, but more effective of actually cleaning stuff off, especially if we're going to do something like a Vash soak, which Anne mentioned. And we'll do that often with faces, especially in the first 2 days that are very exudative for patients in the hospital. And it's most effective to soak it, not so much how much you use, but to actually soak and let it sit on there for 5-10 minutes. And I find that, especially if it's like in this region where something that you can try to secure, taking a single layer of a 4x4, soaking it, laying it over, putting a telfa on top of it and wrapping it up, and let the kids just sit there for a few minutes watching TV or having a lollipop or just any sort of distraction, and letting that do the work for you. But if it's not really exudative, it's not something that we think we really need something like Vash, which is prescription, soap and water. I prefer soap and water over Vash. And there's no, as Anne said, it's more of an art than a science. And there's not like an absolute has to be done this way, but we want the concept of as much as possible at getting clean, old cream coming off, new cream being put on to keep it moisturized and protected.
I think like sometimes like as nurses, we can overcomplicate things and make it feel like it has to be done with this, you have to use this. And like the whole art, not a science, is like, it's a hard thing to explain and understand. But I think that the take home from everything that you and Anne you both said is like warm soapy water. I mean, it's like almost like if your kiddo or if your friend's kiddo or if your niece or your nephew like ran and like scraped their knee, how would you wash their knee? You would use warm soapy water. I mean, and then rinse it off. And then, I mean, obviously we're not going to be like trying to scrape away a scab on a knee, but new stuff can't grow if the old yucky exudate is just like hanging out there. Joe, what do you think? Any
I agree with
tips and tricks?
I agree with everything that's being said. I just don't want it kind of is a little bit confusing, but sometimes we will specify Vash instead of soap and water. Even though with soap and water, you can make it nice and like warm and more comfortable, because a lot of our patients that are admitted do like spike a fever, have viral illnesses. We're concerned about kind of infection and things like that. And we just want to be a little bit more aggressive. And so sometimes we will specify Vash, and we will recommend that for different burns, especially faces. So it kind of depends, and I hate to confound everything, but it really does depend on the clinical picture. But the concept of soaking first, trying to kind of exfoliate and take away all of the old exudate and all that buildup remains the same across the board.
One of the, to piggyback on that, one of the things that nurses will probably see for patients that are admitted, and that we will tell families often in burn clinic, is that burn dressings and what we're using and what our recommendations are change. And yes, some of our patients have the same course from start to finish, but more of our larger burns, more complicated burns, deeper burns, those patients go through several different types of dressings before they're fully healed. So someone may start with Vash in the beginning when they have big, open, heavily exudative wounds, things that we're worried might need further like debridement or that are potentially infected. So we may be using Vash, and then we may back off to just soap and water as it's beginning to either it is healed or as it is healing. So those orders, in addition to also what we're putting on as dressings, will often change during a patient's admission.
I think that's so important for everyone to hear, is that like the burn is changing, so the care changes, and what it was 2 days ago may not be what it is now. And with that, thank you guys so much for doing this. I think it's like great for like our staff to like get to know you guys a little bit better and realize that you literally are the cheerleaders for nursing, and that there's a wealth of experience, and we're all in this together. And just a reminder of like how important facial care is. So what I do at the end of all of these is I'm going to ask you what your most important take-home point is from today, and it can be about anything. And Anne, since you've done this a million times, you're going to go first.
Okay. My most important take-home today, I think, is please reach out to our team if you have questions or concerns. We've discussed the location of our office. We have Zebra phone contact. We have an email address. Like, just let us know if there's something that you really want to talk to our team about, because we are here for our patients and we are here to support nurses.
That's great. Joe?
Yeah, I don't want to copy Ann, but just that our door is always open, you know, and we are all on the same team. I think nurses should always be empowered to like trust your gut, and come grab us if we're available. If not, you know, get another member of our team if it's like overnights and weekends, get the resident. If you're not satisfied with, you know, how that provider is handling things, feel empowered to go up the chain and get help. Because, you know, trust your gut. You have experience, you know when something doesn't look right. And you know, our trauma burn population, these kids can get very sick very quickly, and no one is going to get mad at you for being concerned.
And Catherine, bring us home.
Oh, they've hit the top, the big ones for me. And along those lines of like the facial care and what we were talking about, nurses having this experience and not being intimidated, is that they are really, for the patients who are admitted or, you know, in the hospital, they're the starting point of education and teaching families. And each time we are there, we would, you know, try to teach the families. We are also trying to teach the nurses if they have questions about it, but then they can continue that throughout the patient's hospitalization to get them up and going. So whether it's a patient in the ICU, patient on the floor, the patient in the ER, there's a lot of information coming at them. And I think that nurses, a lot of them know more than they may realize in terms of care, and being able to understand some of the things that may have been not overlooked, but families are getting a lot of information at once. And so one of the things that is unique with burn care, it is a combination of, you know, a lot of our patients have immediate medical needs, but this is also nursing care that's going to continue at home. So if nurses can feel empowered to start that process and start teaching early, I think it will improve outcomes and satisfaction for everyone.
All right.
Can I say one more thing?
Yes.
I'll take Liz's maybe, I don't know.
Okay.
Going back to how we mentioned a couple times that it's an art, not a science. Like, yes, we'll put in what bandage and what treatment we want, but you may even see between the three of us that we're all going to wrap a hand a different way, or we're going to wrap a head a different way, or one of us covers it, this part of the cheek in a different way than the other one does. Be empowered to know that there are different ways of doing things. And as long as we're kind of getting the treatment process that we want, like, it's okay if your wrap looks a little bit different than mine. Or if the bandage that a bedside nurse is doing is, a family says, oh, well, that's not how that person does it. Well, the nurse before, the nurse practitioner who sees you first, or, burns are very dynamic. So our treatment changes, the way that we do things is a little bit different. So, this is something where we have expertise and we're happy to explain to people. But as a bedside nurse, you also can feel empowered that you do have the skill set to do some of these bandage changes, and you do have the skill set to do burn care, either with us or with the parents, or, as Catherine said, being that kind of first aspect of being able to educate the families. So.
Or if I put something on and it looks great and I walk out of the room, and then you have a wild and crazy toddler or even a teenager that wants to get up and move around, and you realize that looked good for a patient who is sitting still, but that's not going to work. That is right there. Like, the nurses are the ones at the bedside. We tell families that in clinic also. We got to figure out what's going to work for you, what's going to work for, like, you as a patient and you as a parent. So nursing can 100% adapt and provide feedback also if they have things they've seen that they think has been working well for a patient or not. That's always helpful to know.
And then my last take home is, if you want more information on burn facial care, BurnCast episode 3 is all about facial care and the importance and some more step-by-step instructions. So thank you guys.
Also a plug, Cindy, last thing, a plug for the Get Well Network videos.
Oh,
really,
yeah.
That are a tremendous resource for nursing families. They can be watched in the hospital. They can watch them at home on YouTube, but just as a reminder for that resource.
And it'll show you exactly how we tell parents how to do facial care. And I mean, you can't go wrong with that. Yeah. So, yeah. All right. Well, have a great day. Thank you guys so much for coming.
Thanks, Cindy.
Thanks for